let's look at celiac disease specifically. How do you diagnose that? How do you test for celiac disease? And one needs to look at specificity and sensitivity. And in the past few years, as I mentioned before, we've gotten more and more serum testing that has become more and more accurate, read specific and sensitive. And it's evolved. And in the past, we used what's called tissue transglutaminase, tissue anti-endomysial antibodies. Those were both IgA. We used a total IgA, and then we also used this thing called anti-gliadin antibodies, IgA and IgG. Now, what we've found, what has been found, that over the past few years, these anti-gliadin antibodies have been shown to be not as sensitive. And so that has been generally replaced with what's called deaminated gliadin IgA and IgG, and that's generally used in the conventional panel because, again, they're more sensitive and specific for celiac disease. However, we lose something when we take that out. Well, in other words, when we're just using deaminated IgG, we're losing, if you will, the forest for the trees. So there is something to be said for this anti-gliadin IgG and IgA. And why do I say that? Well, because while it's not as sensitive, there is good studies to show that elevated anti-gliadin IgG only has been associated in a number of studies with all-cause mortality. That's not a good thing. There's also been studies that show individuals with bipolar have increased levels of IgG antibodies to gliadin, and they don't have any increases in any other antibodies, the tissue transglutaminase or deaminated gliadin. So you throw a not as wide a net when you don't use that anti-gliadin antibody. So therefore, I suggest that we should, and you can still get it, some specialty labs are still doing it, I suggest if you can still get that, you should use it because it is well validated to throw a larger net. So what's the testing? The sensitivity, the serum testing. I mentioned total IgA because there's a higher percentage of celiac patients who don't have, who are deficient in IgA. There's some controversy around that now because now we have IgG, deaminated anti-gliadin antibodies, IgG. So different clinicians will still get the total IgA. Then you want to get tissue transglutaminase. That's generally a screen. And then the follow-up is deaminated and anti-endomysial antibodies are generally the follow-up. There is generally, if you're conventionally, it is thought that getting a confirmatory small bowel biopsy is appropriate. If you talk to a gastroenterologist, they're certainly going to say that. I would say that with this sensitivity and specificity of these tests, I feel very confident in recommending a complete non-gluten diet for somebody who comes up positive with those tests. But conventionally, we're looking at a confirmatory small bowel biopsy. I use DQ2 and DQ8 to rule out the risk of celiac disease in patients who are currently gluten-free and they don't want to go back on. If they're currently gluten-free, you get a DQ2, DQ8, they're negative, then they're never going to develop celiac disease. So if they are exposed inadvertently, they still don't do well. They probably have non-celiac gluten sensitivity, but again, I think that's a total loaded effect. So if they're exposed inadvertently, you don't have to worry or get worried about getting that serum testing, and also first-degree relatives, because if they are negative, if you have I have a mother who has celiac disease, I test her son. If he's negative, I don't need to follow up every 5 years with the serum panel, or suggest that he follow up, because if he's positive for DQ2, DQ8, then he's at risk. So then I would have him follow up every 5 years. So I do think that using that genetic marker, that variation is important in those considerations. And then I do use anti-gliadin IgG to expand beyond that celiac panel, or that conventional celiac panel, as I mentioned. There are all sorts of algorithms I've shown you here from the Mayo Clinic, the American College of Gastroenterology, the American Gastroenterology Association Institute, and the United States Preventative Task Force. They have essentially testing and reflex and retesting. Because I wouldn't say I'm lazy, because I think I just want to get all that testing done at one time. So what I showed on that serum panel, I do that all at once. I don't want to miss celiac disease. I definitely don't want to miss celiac disease, so I don't want to get reflex testing. I want to get it all at once. So that's what I do, but if you want to do a stepwise approach, you can look at any of these. So then, now on to non-celiac gluten sensitivity, and I put that under under the immune side. So how many of you avoid gluten? Just by a show of hands, how many of you avoid gluten? Okay, so quite a few, so maybe 40 or 50%. Now, I'm not going to ask you to show a raise of hands, but I would imagine that not many of you have been diagnosed with celiac disease. So gluten is, as I said, a complicated beast, and we really don't know everything about it. And we have millions of people and billions of dollars being spent on gluten-free products. Well, why is that? Well, it's because there seems to be now a body of literature over the past 10 years that supports the conclusions that something else is going on with gluten, and likely something else is going on with wheat or other parts of wheat aside from celiac disease. And this literature really extends to the 1970s, but the idea really gained traction in this study that was done in 2011. It was small, but it was well done. It was a double-blind, randomized, placebo-controlled re-challenge that showed celiac disease and non-celiac gluten sensitivity were distinct clinical entities. And I would say this was certainly in the literature for many years, but more anecdotally. And so the bottom line, they said, a gluten-free trial is warranted in these patients who had IBS. Another study following on the heels of that suggested there were distinct differences in these two entities with different mucosal responses. And they came up with a diagnostic criteria. Essentially, it's a diagnosis of exclusion. You exclude allergy, you exclude celiac disease, and there is really no lab that's recognized. And although AGA, as you'll see here, and I'll show you, is more likely to be elevated or higher in a percentage of those people, it's not diagnostic. So with celiac disease, there's a lot more symptoms outside of the gut, but as you can see in gluten sensitivity in this study, there are symptoms outside of the gut. All of those symptoms in blue are, you can have the same symptoms or you can have different symptoms. And of course, both conditions can have symptoms within the gut. So you can have extraintestinal and intestinal symptoms in both. So the lab comparisons, again, it's a diagnosis of exclusion at this time. The lab doesn't give us the answer all the time. And there is a trend, as I mentioned, with AGA, as you can see. So there's a trend of higher levels in those. So if somebody has AGA, I'm going to take them off. But that's not diagnosing non-celiac gluten sensitivity. And there's also a trend, or there's a higher number of individuals that are DQ2, DQ8, but it doesn't really tell you that if they're negative for DQ2, DQ8 doesn't mean they don't have non-celiac gluten sensitivity. So there's no perfect test for gluten sensitivity. The perfect test is the gold standard, is an elimination diet that we'll talk about this afternoon. How many people have this? Well, it's not really clear. Most studies suggest between 1% and 6% of the population, although anecdotally, I've seen it as high as 15 to 20% in gastroenterologists. Individuals like Alessio Fasano will talk about 10 or 15%. And the number with reactions to wheat overall may be certainly higher still. So what about this other research that you may have seen that said that non-celiac gluten sensitivity doesn't really exist? And gluten is actually just this fermentable oligosaccharide, this fructan, and that it's all about FODMAPs. This is actually the same group that in 2011 did that other study, and this got a lot of press. And their conclusions were that essentially asserted that non-celiac gluten sensitivity is really a problem of FODMAPs. The study has now been, you can look up Dr. Google and it's referenced all over the place. The problems is there are actually a lot of holes in that study. In the addendum, I give you a number of parts of those holes in that study for you to look at. But there's also been over the past 4 or 5 years a number of studies that make it pretty clear that gluten is more than just a FODMAP issue. And so really perhaps we should take, as this 2014 study says, a more nuanced view of this issue, and we conclude that the population of patients reporting intolerance to a gluten-containing diet is a mixed population of non-celiac gluten sensitivity and of FODMAP-sensitive patients. So there's a lot of things going on with that wheat kernel. So it's not either or, it's both. Some labs are looking at other ways to assess gluten reactions by testing other components of gluten and wheat proteins. And as I've said, gluten is a very, very complicated beast. So there are other components that you can test. Here is one lab that they test. Various technologies have been developed to measure IgA and IgG against various wheat components, including all of these. It's interesting. It's cutting edge, I think. But the jury is still out on the level of research that proves this in the peer-reviewed literature. You can, just because you have an elevated antibody to something, doesn't mean that that's proving you're having a reaction to that thing. We have antibodies to all sorts of things. So finally, with this gluten-wheat-related disorders schematic, let's look at these what we can react to the larger wheat kernel, and there appears to be non-immune mediated reactions. We already discussed, or I discussed, how wheat is involved in FODMAPs, and this is, as I mentioned, the fructans, which is the oligosaccharide. And remember that gluten and wheat have many potential issues from an intolerance perspective. So as I showed on that slide, and that I said we were getting into the weeds, this amylase, trypsin inhibitors, wheat germ agglutinin, which is a lectin, various unidentified protein, antigens, etc. So there are a number of labs that are really using tests that purport to look at various mechanisms outside of these IgE, IgG food reactions. And they use these for gluten, but of course beyond gluten, they use it for testing all sorts of foods. So to be clear, here I'm not just testing about these tests looking at gluten, they're looking at the whole kernel, they're looking at various other foods, and there are a number of tests on the market, such as cell mediator release, ALCAT, MRT, and ELISA, etc. While some of them have been out for quite a long time, they make fairly large claims, but there's really very little literature to support these claims. And I've hidden a few slides of the literature that I've seen. So if we move back out to the big picture of immune and non-immune mediated reactions to food, not just to gluten, now we're talking about reactions to food, and talk about these immune, non-immune mediated reactions, we can see again here the big picture of food intolerances, and we get this, all sorts of things that we can react to. And we're really talking about a vast and varied number of suspects in the form of lactose and lectins, salicylates, histamines, and there's all sorts of formed reactions that we can have, enzymatic, pharmacologic, and it's what's in the food, it's how it's preserved, it's how it's cooked, So you can have all sorts of effects, and even one of my favorite foods, coffee, seems to have some effect. So but there are all sorts of things, non-toxic things that we can have effects on food, and we actually look at all of these things in our comprehensive elimination diet, or almost all of these things. Here's just a list of some of these. In the comprehensive elimination diet, we're able to individualize that. So if you're looking at salicylates or looking at high histamine foods, Dr. Bischoff will talk about that in the afternoon in terms of if you have a high index of suspicion, you may want to do something specific to that. She'll tell you how you're able to do that. Lactose intolerance is certainly certainly in certain populations, it's a very high. It's probably the most common food intolerance, but it is, if you think of lactose intolerance as the model for FODMAPs, it's an example really of FODMAPs, which I explain here. We talk about FODMAPs a lot more in the GI module, but FODMAPs, again, very briefly, are these fermentable oligomonosaccharides and sugar polyols that include fructose in fruits and vegetables. They include lactose in dairy products. They include galactans in legumes, fructans in wheat, as I said, and fructans in artichokes, and a number of other things. And there is a lot of research around FODMAPs. As we mentioned, I don't necessarily think it's the food's fault. It's often a motility issue. However, temporarily eliminating FODMAPs may be useful. We have a toolkit handout, a couple of handouts on the right-hand side. Monash University has an app that's like $4 or something that you can get on your phone. So there's a lot of ways to use FODMAPs, and I would suggest that using those toolkit items if you suspect FODMAPs, and if you really want a deep dive into FODMAPs, we go into it in the GI module. So how many people fall into this bucket of food intolerances in distinction to the NIAID, which said, about 1%. This is a literature review that says maybe 15 or 20% of the population, maybe more. And certainly that is higher than the NIAID suggests. So what are the clinical factors for food intolerances? Well, we're looking at a lot of the same things. We're certainly looking at medications and micronutrients, as we say here. So there's a lot of the same kinds of factors when we're looking at food intolerances as when we're looking at immunological mediated food reactions. So for 5 minutes, what I want you to do, let's go back to Joan. And so now let's think about her again in her case. And so in each table, what kind of laboratory testing from what I went over would you suggest that Joan should have, or you might want to have, or would you do some sort of just elimination diet? And so there's not necessarily a correct answer here, but I want you to talk about that for 5 minutes and see what you come up with. As I said, there's not a perfect right and wrong answer to this, although I would hope that from what I've said over the past hour and a half that you're thinking about doing at a minimum a celiac panel in her, given the level of symptomatology that she has that could suggest that I don't think you want to miss. Whether you do an IgG food sensitivity testing is another question, but that's where I would come down on this. So finally, what's the rationale for evaluating and testing for food reactions? So I want to first say let's not overthink this situation. And what do you do in particular on Monday morning? And, I don't want to, if you will, eat ourselves into a hole. So we got to be careful again of not getting too involved in all of the minutiae about this. So first you want to ask the question, could something in the patient's diet specifically or environment be causing these symptoms? And then it seems reasonable to consider, could foods be causing a problem? Here's a synopsis from Medscape. So again, we're not making this up. There are a lot of reasons that foods can be causing a problem. And what are the two top problem foods? Well, gluten and wheat with celiac disease, non-celiac gluten sensitivity, wheat allergy, dairy with lactose intolerance, a milk allergy, a casein sensitivity. We may be talking about certainly on the order of a fairly, maybe a fifth of the population conservatively are potentially having some reaction there, maybe more, maybe a lot more. But certainly we should be thinking about those two top problem foods. You want to look for clues. You want to look for clinical clues, as Dr. Salt talked about yesterday. You want to consider testing for a dietary trial. Dr. Bischoff will talk about a dietary trial. Do you want to do serum testing for IgE? Do you want to do skin testing? Do you want to do other testing in terms of a celiac panel? What kinds of important immune support are you looking for? Intestinal permeability. And then you really want to look at we have a lot of handouts, we have a lot of ways that you can very easily work with patients. Clearly you have to work with them, but we have a lot of ways that gives you background and foundation for working with them. Fourth, you want to consider evaluation using this 5R framework. We want to, I think hopefully we've made it clear that this is a significant area of investigation and treatment, of looking at intestinal permeability, looking at the gut microbiome, etc. Fifth, as Dr. Roundtree said, at some level I agree with him, you certainly want to look at specific symptom control, pharmacologic symptom control, and then you want to look at natural, botanical, and nutritional symptom control. We have some handouts in Dr. Roundtree's talk about looking at some of these anti-inflammatory nutrients, these mast cell stabilizers, stinging nettles, and quercetin, as Dr. Roundtree talked about. You want to remember about the acute emergent mus. There's no question about that. You need to understand if it's an allergy and anaphylaxis. And then 6, you want to, if you're looking at reintroduction, if you're thinking it's a IgG positive food, you don't want to reintroduce before 4 weeks for the reasons I suggested, and you may go further than that, as Dr. Bischoff will talk about. And then IgE foods, as reintroduction is dependent on the reaction and the interventions of immune modulation, etc. And I think the bottom line here is, do you think something in your patient's diet or environment is causing symptoms? Decide if you need to test, decide what you need foundationally, and decide what you want to do as a therapeutic trial. And finally, I'll leave you with Dr. Sidney Baker, who's one of the kind of founding fathers of functional medicine. He's a pediatrician. He's still practicing. He's in his 80s in Connecticut, and he has this tack rule, and he says, if you're sitting on a tack, it takes a lot of aspirin to make the pain go away, so perhaps you should just remove the tack. And the second rule, if you're sitting on 2 tacks, removing one doesn't necessarily result in a 50% improvement in symptoms, so maybe you should be thinking about removing a number of tacks. And the last thing I'll leave you with is a famous physician, Archibald Gourad, of over 100 years ago, in 1908, I believe, he published a book called Inborn Factors in Disease, and he redefined what he called diathesis as susceptibility based on individuality. And he said, in every case of every malady, there are 2 sets of factors at work in the formation of the morbid picture, namely internal or constitutional factors inherent in the sufferer, our genes, and usually inherited from our forebears, and external ones which fire the train. And I think that's what we're really always learning, old things in new ways, and it's really from 1908, he says it far better than I can say it. There are 2 sets of factors that we need to look at.